Hi, everyone. This is Lisa Marsh Ryerson, and I'm so pleased to be with all of you today for our momentum discussion where we'll be talking about social isolation and particularly about social isolation during this time of the pandemic, or as I would say, the pandemics. So certainly during the time of COVID-19, of economic downturn, and of the ongoing pandemic of systemic racism and discrimination in our nation as well. I'm going to be joined today by three outstanding leaders in the field. So we're looking forward to having this conversation with all of you. But before I jump right in, I want to share a shout out and congratulations on the 75th anniversary to James Appleby, the entire team at GSA. I know AARP Foundation, all of us are celebrating your 75th year anniversary, and we're so delighted to be part of the important GSA community as well. Also, a huge thank you to James for serving as a key member of the Executive Council of the Connect to Effect platform work at AARP Foundation, which is our long-term commitment to draw attention toward important research in the field and to build a body of evidence-based solutions and interventions that individuals who are struggling with isolation and or loneliness can be directed to. It's part of our commitment to working with communities across this nation. We're happy today to be talking with you just several months post the launch of the National Academy of Sciences, Engineering, and Medicine study on social isolation and loneliness among older adults. And this study is so important because it looked at healthcare overall and ways in which we can raise awareness of the topic, improve diagnosis, and improve connections to community-based solutions across the nation. Very happy that Robert Espinoza, who was on the panel, served on the consensus study committee, and AARP Foundation was the proud sponsor of that work. But of course, the world has changed a lot, even since the launch of the study in 2019. What I want to call attention to is that it was so terrific to work with NAS and with the committee, and I'm pleased to note that the study remains one of the top downloaded studies in all categories at NAS. So clearly, this is a topic that's on everyone's mind. What we all know is that social isolation had already reached a public health crisis point pre the pandemic, and certainly much has shifted since the pandemic began. We also know that prolonged isolation is related to many conditions, including earlier death from all causes. And we know that we have much to do to increase awareness, to increase connection to resources. And part of what we have to do is continue to fund and explore both research in this field as well as innovation in addressing social isolation. Recently, AARP Foundation fielded a survey with the United Health Foundation, and no surprise to anyone who is joining us today, we found that 2/3 of all adults say they're suffering from social isolation during the pandemic, and 41% of those who responded reported feeling more anxious than usual, and more than 1/3 confirmed that they're feeling depressed. Social isolation, of course, is an issue that affects people across all demographics from all backgrounds, but low-income older adults are at greater risk for social isolation and its effects. It's an issue that is connected deeply to poverty and to all social determinants of health. And despite this, progress is being made, and today people are more aware of the importance of social isolation and addressing it. And I think we have to take advantage during this time of the shared experience of isolation that is occurring across society to push forward the issue and solutions for it. There's also been quite a bit of progress made on the key recommendations from the NAS report. The NAS recommendations have been guiding the work at AARP Foundation since its launch. I'm really pleased that we've been working with Robert and with Kelly and the team at ACL and with Abby Sears and her team at OCHIN to forward these recommendations. So now let me introduce a terrific panel of experts. We're happy to have Robert Espinoza with us today. Robert is the Vice President of Policy at PHI, where he oversees its National Policy Advocacy Research and Public Education Division. In 2020, Robert, congratulations. Robert has been selected for the first ever Care 100 list of the most innovative people working to reimagine how we care in America today. Robert is a nationally recognized expert, a frequent speaker on aging, long-term care, and workforce issues as well. And as I've noted, he was an active member of the NAS Consensus Committee. Joining us also is Kelly Cronin, a wonderful colleague. And Kelly is the Deputy Administrator of Innovation and Partnership at HHS's Administration for Community Living. Kelly is a health IT pioneer in the public sector, helping to establish the Office of the National Coordinator for Health IT. And Kelly, I think I'm right in saying that, in fact, you were the first employee of that division. With ACL and CMS, Kelly has worked on person-centered, people-first planning and integration of long-term services and supports into healthcare for older persons and people with disabilities. And Kelly has led and continues to lead efforts to advance federal policies to foster a truly connected healthcare system, including the integration of social services as part of value-based care. So a huge welcome to Kelly Cronin. And finally, I'm delighted that we're joined today by Abby Sears. Abby is the founder and CEO of OCHIN, a nonprofit healthcare innovation center designed to provide knowledge solutions that promote quality and affordable healthcare for all. With health equity as the driving force behind Abby's leadership at OCHIN, Abby is focused on building a premier information and technology network, leveraging health IT products, services, and the use of practice-based research to help community practice nationwide achieve federal and industry standards for healthcare delivery, quality, and cost control. And Abby was also appointed to the Federal Health Information Technology Advisory Committee, HITAC, where she will work to help elevate the voices of patients and providers in historically underserved communities across the nation. So warm welcome to Robert, Kelly, and Abby. It is so wonderful to have such leaders and innovators with me today as we talk about social isolation as a growing public health crisis. And I want to start by having each of you talk a bit about how your organization and you as a leader are thinking about the recommendations from the NAS study, or maybe implementing them into your work. And additionally, how are you responding to the increase in social isolation during the convergence of pandemics? And Robert, I want to start with you as you served on the committee.
Thank you, Lisa, and thank you, GSA and my fellow panelists. You know, when the report was released in February, because the direct care workforce was a big part of the report's recommendations, we issued at PHI immediately an analysis on all of those recommendations. For those of you who haven't read the report broadly looks at the challenges facing older adults in regard to social isolation and loneliness, and it makes a variety of recommendations for the entire healthcare workforce, which includes the direct care workforce. So often healthcare workers are the primary supports for people who are severely isolated, and many older adults interact with at least one healthcare professional. And we see this in the direct care workforce, where for many older adults, whether it's in their homes, in nursing homes, or in assisted living facilities and other residential care settings, their direct care worker is sometimes their only source of support and interaction. So we felt strongly about the report's analysis and recommendations, and we issued an analysis early on to educate our sector, the direct care workforce, the long-term care sector, the variety of actors who shape these jobs and shape this delivery of care. I think one of the major challenges we face, and I think we'll be talking about this through the call, is that COVID-19 emerged shortly after the report was released. And it shifted our attention to looking at what were the emergency needs of workers and the sector during this moment, because we can imagine that it amplified isolation and loneliness for older adults, especially in nursing homes where the virus had a disproportionate impact. But of course, in the variety of the entire sector, of course. So we've deepened our analysis on helping the sector navigate this crisis, ideally to support isolated people and people with loneliness, but the entire sector as well. And we saw some major challenges that I'll talk about later on in this call. We saw the home care workforce contract in the first 3 months of the virus for a variety of unfortunate reasons, which can leave older adults even more isolated. I think as we think about the value of this report and a way forward, we should think about both how do we navigate this crisis to support people dealing with isolation and loneliness? And how do we think long-term and imagine kind of a much stronger aging and long-term care sector?
Thanks so much, Robert. I think it's, your responses are helpful in so many ways because the study, we intentionally, as you know, looked at healthcare with a broader definition. I think it's so critically important that we grow the understanding of healthcare workers and healthcare clinicians across the entire system of healthcare. And also, as you noted, and I want us to talk about throughout our dialogue, the pandemic has laid bare issues that really existed pre-pandemic. So we're called now to be sure that we're solving more directly for many of those issues. Kelly, I want to move to you.
Sure. So yeah, I'm in some ways, the last 9 months have been this clearly a challenging period for so many reasons, but also a window of opportunity to really address in a significant way social isolation, because it became, well, arguably it was an epidemic before the COVID, but on top of the pandemic, it became such a pressing, prevalent issue, even more so than beforehand. So as it pertains to the report, I think we've been doing the most in the area of recommendations or goals 3 and 5. Goal 3 being around increasing public awareness. And in goal 5, there was a specific recommendation for HHS to stand up a coordinating center, a resource center, to try to, collate evidence and put resources out there, best practices. And in fact, we have been working across many organizations, including AARP Foundation as a key partner, given you've had at least 8 years of a really strong portfolio in this space with a lot of expertise in-house. So AARP Foundation, Leading Age, National Council on Aging, and many other organizations, Meals on Wheels America, we've all been coming together to figure out how can we have a more coordinated effort across the public and private sector to understand how the evidence base is growing, what's working in our collective programs, what are our opportunities to reach many different subpopulations through our collective membership and our reach through our programs. So how can we get through to housing? How can low-income housing? How can we get through to community-based organizations that we fund, senior centers, assisted living, and other settings. So having this sort of more cohesive both resource center and a coordinating center around this initiative really allows us to not only organize that information and disseminate it in a way that's impactful, but it just to really collectively have impact across the public and private sector with, among organizations that are most engaged and have the most relevant reach. So we're really excited to be now just in the beginning stages of funding that and standing it up. Again, building from many months of collaboration across these organizations. And then as a part of that, they're going to be coordinating a broader public health awareness campaign. So this will be in collaboration with ACL and HHS. And so we'll be wanting to get, for example, the Surgeon General and our other federal partners. We've been working closely with the Office of the Assistant Secretary of Health, for example. And then again, try to partner to create common messaging and how can we get some core messaging and potentially tailored messaging out to subpopulations on a broad awareness campaign. And then not only just increasing awareness, but doing it in a way that we can then connect people to the right resources that will be meaningful for them, that will make a difference in their lives, given their capabilities, their interests, their preferences, what really matters to them. So that we're excited about, and again, have been working on for quite a few months in the planning stages, but we're just now turning the corner where we're ready to gear up. And since we're also, as we know, in the middle of a surge, it's still very relevant to work quickly and rapidly across organizations to really get something done. So it's a window of opportunity to make a lot of progress, and we're all highly motivated to do that given the amount of people that are suffering now.
Kelly, it's such a joy for my team and I to work with you and your team and all of the other organizations, and want to commend you for leadership in this work, because strategic partnerships matter. As you're noting, no one organization can end isolation or address it wholly and fully on our own. It very much is about gathering together a community of practice, organizations and leaders who've been working in this field over time, being sure that we're redundant where we intend to be, and that we're lifting up other good work. And your expertise in data, I want us to get back to that, because data really matters. You know, we do have to collect evidence, qualitative and quantitative evidence, so that we're lifting forward evidence-based solutions that will really help individuals and help communities make progress in this space. So looking forward to hearing more as all of this work and the partnerships unfold. Abby, delighted that you're with us and look forward to having your voice join into this dialogue. So I'll turn to you.
Great, thank you, Lisa. And I think I'm having some internet issues. So if I come and go, I apologize in advance, which actually I'll get to in what I'm going to speak about a little bit. First, I want to thank you, Lisa. Yeah, first I want to thank you, Lisa, and AARP for helping us build this relationship with OCHIN. This is the work we've been wanting to do for 20 years. Is finally having enough data, having enough of a patient population to be able to tell the story of what's going on for some of our most vulnerable patients around the country. And I really think of us as kind of an innovation lab. We're in 47 states. We touch over 6 million patients and over 20,000 providers. So the story we have to tell is a very big data set, and it really tells a very interesting story. So I want to start with what we saw in the beginning of COVID and what we're seeing now in this time of the COVID, and then some of the things that we began to implement and what we're learning from that, and then what we're learning now and what we're executing on now. First of all, as I was saying, we have a really large data set of patient population. And of that, I think it's really interesting to know that within the first 30 days, we were able to get about 90% of our organizations up on telehealth within 30 days, which is just remarkable number. I mean, we're touching over 500 organizations. So that's a lot of organizations. They're swiftly moving to telehealth. So that's the first step. Can we actually reach these patients, whether they're in rural areas or urban areas, whether they're young or whether they're older, and everybody's sitting at home. So can they get care? And how do we get them to continue with their care? Our patient population tends to be about 70% have a chronic disease, another 50% diagnosis, and another 50% have in their top 8 diagnoses, they have mental health issues. So they're very complex patient population. They've got to continue with their care regimen and their treatment plans. So as we saw that, what was interesting was that our patients with from 50 to 64 have really adopted to telehealth actually quite well. They're one of the leading users of telehealth actually in the entire system, which is really remarkable. Over 65 though, and I think roughly about 30% are actually actively still being seen on telehealth services. So that's the good news. What I'd say is a more challenging story is in the beginning, the over 65 had a little bit more, and I mean like a percentage or two, and it's going down. They're roughly being seen at about 5% on telehealth. One of the interesting things with the over 65 age, which really is hitting on the social isolation conversation, is not only are they not being seen on telehealth, but when we look at the face-to-face visits, they're also not going into the clinic. So our over 65, which are pretty complex patients, are not being seen anywhere unless they're showing up at the emergency room. And I don't have access to that data at this time. We're just beginning to get that level of data and looking at the story that is being told. But what we're really seeing when we look at our screening for social isolation, which we have about 565,000 screenings on social determinants of health in our system. And it was roughly screening at around 19% for social isolation, meaning every time a patient was asked, about 19% of the patients were saying they felt socially isolated. Now it's running upwards of 30-35%, which is exactly what you would expect to see in this. The problem is that age 50 to 65 year old also is transitioning to telehealth services for mental health services pretty well, but the 65 and older are not. And they're not being seen by any mental health providers. So the age 65 and older are not going into the clinic. They're not getting telehealth visits. They're not getting any behavioral health support in any way, shape, or form. So one of the things that we started working on before COVID with AARP was the social service record locator. And that's a really technical term for how do we connect with our community resources? We're predominantly primary care, public health services. How do we reach out to get rental assistance? How do we reach out to social workers? How do we reach out to translation services? How do we reach out to any other sort of support services that an elderly patient might need support around? Meals on Wheels is a great example. And we were just beginning that work, and COVID hit, and it kind of took us a little while to gear back up on that. And we've been getting a little bit more information and data on some of the pilots that we have running on that. We have some great examples where within the same day they were able to get Meals on Wheels connected to this patient population, where they were able to get rental assistance and keep people housed this time period. So those community partners, I think what I'm trying to communicate is those community partnerships are incredibly important, especially in the 65 and older age group, because they don't have another avenue. The other thing we're seeing that as we went in and doing telehealth services, the older population is struggling with smartphones. The tools that we all think are everyday tools, they don't necessarily use them in the same way. So we've started a patient help desk, if you will, where they can call us and we'll walk them through. I have a great example of our operations. Our lead operations person spent 5 hours with her grandma, walking her through how to Zoom with her provider one afternoon. So they need a lot more support than what our clinical provider organizations really have the time to do.
Yeah.
And so we're trying to put more support in place to actually help them. We have deployed tablets that are really easy to use. We've donated those. We've worked with vendors, Microsoft, Amazon, and really tried to help get more equipment out into the field. We leverage government programs like the FCC program, and we were awarded $2 million, and we sent out monitoring devices out into the homes for chronic care patients so that they don't have to go in and we can be monitoring them. And again, that's another touch point and conversation and keeping them from being isolated. Those are the sorts of things that we've been kind of focused on.
I'm going to jump in, Abby, because you all three have hit on so many important topics and sort of bounce off on what Abby's reminding us of. And certainly there are many attendees at GSA who are researchers and community leaders in the field of addressing isolation who understand it. The report, Robert, really speaks about, first and foremost, understanding the difference between loneliness and isolation. So as we think about isolation broadly, it is definitely having a reliable social network of individuals, but it is also having, as Abby is saying, those critical connections to community resources that help build or maintain resilience and the ability for individuals to thrive. So Kelly and Robert, I'd love for you to jump in on this. Kelly, when I think about the coalition that you've really built with your colleagues at ACL, it is all about community connections. And Robert, in your work, it is as well, both for patients that direct care workers are serving and or for direct care workers themselves. What barriers have you seen emerge around our ability to help individuals access community resources? Or maybe how have you successfully overcome those barriers or seen success stories? Any Robert or Kelly, you want to jump in there?
Sure, so I'll jump in first. So it's a barrier for direct care workers in particular. When you think about the direct care job, primarily a low-wage job, and many workers rely on public benefits to survive, and many are in poverty. What we also see is that because this workforce is primarily female, people of color, and immigrants, often workers are facing an array of life barriers that make it difficult to stay on the job and to do well on the job. And it's those community resources that are specific to their populations and their needs that offer the kinds of supports for workers to succeed and be healthy, right? And so, unfortunately, we've seen most is that too often direct care workers live in communities where they don't have access to those resources. Those resources aren't well funded either by the public or private sector, and workers don't feel secure on their job and supported in their lives, they're not able to deliver the support that people need, and that includes older adults and people with disabilities. So I think it is absolutely central to strengthening both the workforce and the care system.
Yeah, I think, Robert, that is, and I want Kelly to jump in. I think you're making such an important point about employers really thinking about. So when you think about it across healthcare organizations, focusing in on the individuals we serve and those who are helping us with the service is so critically important. And you're also reminding us, as you were talking about the identities or intersectionality of identities of many direct care workers, those are demographics that in a lot of research have been identified as individuals who are at heightened risk, right, for isolation. So certainly women, people of color, those who identify as LGBTQ, caregivers, immigrants. So you've inserted something very important into this conversation regarding solutions. Kelly, anything you'd want to add?
In terms of barriers to connecting, yeah, I mean, I think generally speaking, most years through the Older Americans Act and the funding that ACL receives, we reach about 10 million older adults in a variety of home and community-based services. So we're automatically connecting them to community services as a part of the everyday work. But I think recently, in the last, say, 3-4 years, there's been an increase in technology innovation to try to better connect between healthcare, health plans, and health systems like OCHIN to the community through closed loop referral systems. So they have sort of referral directories or community resource directories that can be used to search and find the right kind of community resources for a person's needs after they're screened and assessed. So having that, more streamlined closed loop referral process has been quite helpful. There have been some challenges in the way that's being implemented that we're trying to address. So right now it's a quite siloed effort and there's a lot of duplication happening across health systems and health plans. But I think there's actually a lot of willingness across the healthcare industry. They'll have a lot of health plan leaders to address that right now. So there can be more interoperability. We have more streamlined connections that won't all rely on separate databases. Like even in Oregon alone, there's many different community resource directories, and we don't need to be duplicative that way. So we're working on those challenges, but I think generally speaking, under COVID, we've had this extra layer, of course, having to do everything remotely. So the senior centers haven't had staff there, or the local area agencies on aging haven't had all their staff working in person, or in our state health insurance assistance program and our MIPA programs that connect people to benefits and low income subsidies and SNAP. Everybody's working remotely now. So there's been that, I think, pretty efficient switch. I mean, everything that we've heard, the 15,000 counselors right now that are trying to counsel people on their Medicare benefits are working well remotely through phone, through the web. So everybody, the healthcare's had to make this switch, but I think the aging network has also made the switch to remote operations, and having the technology capabilities to make sure that all the service providers can have visibility into who should they be serving and tracking them and being accountable for making sure that things get done is very helpful. So I think there's still a lot of barriers that we need to address, and another big one, honestly, is just, and this is going to take a number of years to work through, but we haven't had adequate investment in social services over a long period of time, right? So it's wonderful to be able to, refer people to get rental assistance or create more housing stability, or get home modifications done, or have, short-term and then enrollment into SNAP, or a continuous amount of nutrition support over time. That all takes funding. And while the federal funds or federal programs are there, and we're doing our best to enable blending and braiding of all these different resources, we're going to need a more collective, organized investment that is made available at the community level. So we're in the process of working with a lot of health plans on how through Medicaid managed care, through Medicare Advantage, through ACOs, through shared savings arrangements, how can we all look at the benefit structure and make sure that there's over time evidence-based decisions that are made that, you know, these services that address these social determinants of health, including social isolation, can be paid for in an appropriate way so that the community organizations that are really on point for delivering these interventions are not starved. If they get a lot of volume and referrals, that's wonderful because people need that. But they have to actually have the people and the resources to deliver the services. So getting that financial sustainability down is a really important piece.
Yeah, I think Kelly, and I want Abby and Robert to jump in robustly here. You've identified so many issues, and you're repeating an important theme, really all of you are, which is we cannot miss this time period. You know, the crisis of isolation is growing, and yet awareness is as well, and we need to jump in and meet it. I want us to talk more about the CBOs and robust funding, and I want to put it in the context of a wonderful report that was put out by my colleagues at AARP's Public Policy Institute that found, and this was a couple of years ago, so likely the numbers have increased, that for older adults who are enrolled in Medicare, social isolation increases spending by about $7 billion a year. So Abby and Robert and Kelly, you're reminding us that the social determinants are important, you know, where people live and work and are educated and grow. We have to address what's happening across the life course so that individuals can thrive and remain connected. And it's the social safety net, and it is also funding for community-based organizations. So if anyone else wants to jump in on that, I think it's really important. I also think this notion of stopping silos is important because it's about effective use of resources, both people resources, talent resources, and financial resources in communities as well. So I'm seeing nods, but open to all. Abby.
Yeah, I have a couple of things. I think one of the things that will help on some of this is that as the industry matures more and as we require technology companies to be more patient-centered than what they are, we will begin to see more culturally competent tools. 30% of our patients, English is a second language, and so it's not their predominant language. I mean, imagine being over 50, having the challenges, needing to be connected to social services. We don't have the standards for the community-based organizations to know how to move data. Those standards have not necessarily been articulated. So you don't even, when you do move data back and forth, you don't necessarily know if it's the same from organization to organization. So we've got to answer that question. So as clinical people and as people in the community, we can trust that information. But we also need more bandwidth. We need a stronger network, just like we invested in the telephone systems, you know, early in the 1900s. We haven't invested in the same significant collective way. We do invest in it, so I don't want to say that we're not, but not in the way that we have in the past in some of these infrastructure projects. And we're really feeling that now, because there are people that literally from an equity standpoint don't have access. They don't have broadband access. So how do we even reach them? They're going to be even more socially isolated. We've got to have more culturally competent technology that's got to be able to meet patients where they're at. And I think we need more trained workers all around. Not just in IT and health IT related to delivery systems or health plans, but in those community-based organizations. How do we build a workforce that understands technology? I laugh and I use me as an example for our whole organization because I'm about the most technically challenged person you're going to ever meet. So I tell them all the time, if you can teach me, you can teach anybody. And so I'm their hurdle, and I'm not an easy hurdle. So one of the things we have to do is find ways to enable those things and make those connections easier so that we are making that easier. I mean, if they're not living with another person and they're living on their own, how are we gonna get to them besides a face-to-face, somebody showing up at their door? We've got to find more connection points like that.
I think you're right, and I would want to hear from Robert and Kelly on this, and you raise important issues about cultural competence and care, but also about digital inclusion, and how do we ensure that we are really using the best of DEI principles as we're building equity as a framework for digital inclusion, and how do we build digital tools that are themselves culturally competent or using best practices. And this is about, I'm kind of looking at you, Robert and Kelly, as well, because this is about policy, this is about innovation, it's also about practice and adoption. And if we don't address digital inclusion, we are leaving people further behind.
Mm-hmm.
Robert,
Yeah.
do you want to jump in?
Yeah, absolutely. That's right. And people who are real experts in the digital divide, both among older adults in general, will point out a number of reasons why that's the case. It's you live in an area without sufficient broadband access, there are financial issues, you may not have the savvy in technology, literacy issues, et cetera, right? And I think that so much of what I see in the social isolation and social connection field in terms of interventions is increasingly about technology. And I think there's a great promise in that, and that
Yes.
technology is in many ways ubiquitous, and I think it will reach more and more people. But unless we address those disparities in access to technology, it'll make it difficult to really be successful. And as it relates to diversity and inclusion, I think we must pair it and root it in frameworks around just diversity, equity, and inclusion. We need to look at, it starts often with data, like does our technology intervention, is it shared equally among people of color, among women, among older people, people with disabilities, et cetera. And we can learn a lot from the disability rights field in this sector. They have a phenomenal framework and a long history of success in kind of really pushing the industry to be more accessible in a variety of ways. And so how do we push that tech industry to think about equities across multiple dimensions?
Terrific. Kelly, do you want to weigh in on digital inclusion?
Yeah, I mean, I think there's actually a lot of interest right now within government and private sector and community leaders to really address this issue, and for the older adults in particular to get more high-speed, low-cost internet access. And so I think we might be on the cusp of seeing some more organized initiatives, cross-cutting initiatives to try to reach a larger proportion of older adults, recognizing that we're really in a time where that it's more critical. And so, we'll see what resources might come out of it if there is another wave of funding from Congress related to the pandemic might allow for some resources to be spent. But I think even beyond that, there's just some among internet service providers and some community industry leaders that they want to address this issue in the coming months. So I'm really encouraged by that. And I think in terms of user-centered design, whether it's for a low-income Latino population or various groups that have different accessibility needs, I think there is at least a part of industry that's very in tune to that. I would say most of the major technology vendors have incredible efforts around accessibility, and they collaborate on it. They're not competitive about it. We probably need to do a better job overall of training people on those accessibility features so it's easier for them to use technology. Not everybody knows what Apple's offering or what Google or others are offering. There's a lot that's voice activated now and many other features. And then I guess there's also, like, for example, in Florida, they have a really neat project, Project Vital, where they're donating tablets to long-term care facilities.
Yes.
It's preloaded software, including some that was developed in partnership with the Alzheimer's Foundation. So they did take that user-centered design approach and really customized it to a population with dementia. And I think we need to see more of that in different kinds of older adults in these different populations that are vulnerable and hard to reach. And we need to make sure things are designed with their interests and their needs in mind, that are easy for them to use and they want to use. The only other thing I'll just mention really quickly that Abby mentioned, because I really agree that we are on the cusp of a lot of good standards development, but it's not mature enough. So if we look where we were 15 years ago with pharmacy, we were able to connect the whole pharmacy world because we have mature standards and there was a willingness to do it, and that happened. We're on the cusp of just investing in stuff like the Gravity Project, which is really well-organized effort that has like over 700 volunteers involved, and will be standardizing social determinants of health effort or data. So right now it's limited to food insecurity, housing, and transportation is being done, and then they're mapping out to include social isolation. So that will be something that over time we can use to standardize the data, and it'll help with measurement as well. But there's also the need to sort of standardize the communication and the protocols of getting data from point A to point B, which could be enabled in part through those higher implementation guides, so which is technical speak for just basically open APIs. But then we also need to really reinforce the adoption among the technology vendors of a human services data specification. That is a mature standard. It has an open API on top of it. It will help get more standardized resource directories and make them more open. And we really need to push that. And we are through a challenge, challenge competition we have going on. We're really trying to get that group of vendors to be motivated to do that.
Yeah, and you've hit on a lot, Kelly, that's been coming up in the Q&A chat. So I'm glad that you did. We had many, many questions around the need to robustly include engineers and system designers in the work. So I'm happy that you addressed that. And also the need to have patience, which I do think a research community understands. And Abby, thank you for lifting that forward, because this is a problem that is a public health crisis and we want to solve, but we want to put forward solutions that we know work. And, you know, in an era where we want the answers just like this, we have to be careful, right? What are we, as the NAS study says, diagnosing, you know, understanding when someone is at risk or has isolation, then connecting them to a solution and being sure that we have evidence that that solution is working, connecting that through the medical record, and then being able to offer it to more people. So Kelly, I'm glad you and Abby hit the patients priority as well going forward. Abby, you also talked about telehealth, and we've all hit on it in some way, and it's been coming up quite a bit in the chat. So also, I would say to you as panelists, you're very patient with me diverting from our Q&A list. I'm going right to the chat because there's such a interest in thinking about telehealth, thinking about telehealth access. I think this relates to a lot of what James and speakers talked about yesterday in terms of also destigmatizing older adults and technology. You know, if we provide access and learning tools as part of our interventions, there's abundant evidence that older adults can and will adapt and will adopt as well. But many of the questions are related to access to telehealth, financial support for telehealth, either in a care setting or in a home setting. And then Robert, as it relates to your expertise in long-term services and supports in long-term care, you know, what are we seeing about growing social isolation and how we address it, both for those living in facilities and direct care workers? Because as Kelly said earlier, the pandemic is ongoing, and we all know that it is. So jump in on that full, robust, connected set of questions. Robert, do you want to start?
Sure, thanks, Lisa. I think to your latter question about what are we seeing in nursing, homes, in the broader long-term care sector. With COVID-19, I think we saw a few challenges related to isolation. In nursing homes, many residents, because of an order from CMS, were relegated to their rooms, and they were pulled away from communal settings, from, you know, the dining room areas, other areas. There was also a lockdown where their family caregivers were not allowed to visit. My mother's in a nursing home in northern Colorado, and she doesn't have function in her arms anymore, and so she couldn't dial out, and there wasn't enough staff to help her dial, and so no one spoke to her for 3 months. The virus, right? And this is devastating. It tells us that as a sector, whether we're talking nursing homes or home and community-based services or residential care, we sometimes don't have the adequate staffing or the supports to keep people connected and keep people from veering into loneliness. And this is an area where I think public policy can really have an impact. I think that we need, you know, governments need to better support, you know, through funding, but also maybe through new research, these kinds of telehealth interventions, and also the barriers that prevent telehealth intervention. Is the barrier not knowing technology? Is the barrier fear of it? Is the barrier there isn't a staff member who's available to support them? I mean, is the fear, my father is into technology, he's afraid of scams. Like what impact does that have on people's views? And the more funding that goes into this sector and understanding telehealth, we'll be able to tap into its promise, and we'll also be able to be honest about its limitations. And that's an important piece. The final piece I'll make here is that, oftentimes I get asked, is the future of home care robots? Are we, if there aren't enough home care workers moving forward, might we solve this crisis by, through technology, et cetera? And the answer for the most part, no. Most in-person care requires a person. And oftentimes workers provide emotional support and they do problem solving, bathing, all of that requires in-person support. However, there probably are ways in which we might consider supplementing some of the tasks or supporting workers through scheduling or through certain technologies that would make the job easier and that would better reach people who are more isolated, like in rural areas where there might be fewer home care workers, right? I think so I think the more that government can invest in better understanding that dynamic, I think the stronger we'll be in the future.
Yeah, thank you. Abby, Kelly.
Yeah, there's some interesting research data that suggests that, our patient population tends to have a high no-show rate for visits across the board for a lot of reasons. And there was an interesting study done where when they talked about we have a social determinant around transportation, they thought that by getting a Lyft contract would solve the issue for them, or an Uber contract, and getting them transportation services. But when it really got down to it, what they found out what they meant by that was that their world was challenged and unpredictable, and the day would get away from them because they were taking care of their young kids or they were taking care of family members. So the ability to actually leave and go to the visit and to come back was actually much more complex story than what the social determinant screening was actually articulating. And what we found, which is interesting because we're talking about all the challenges with telehealth and with the digitization of all of this, but the real opportunity we're seeing as well is our appointment rates, our no-show rates have gone down to under 5%. So when the patients feel in control and they have the ability to adjust the schedule and they don't have to get in a car and drive and lose time, they're more likely to keep their visits, they're more likely to keep their treatment plans. So I think that's the positive side of all of this, that's going to actually improve some of the equity issues that we were seeing related to some of the social determinants. If they are a multi-generational home and they can take care of each other and have them make those visits and make sure they're supporting each other, that's the opportunity in a lot of this. So I'm really excited about that. What we've got to make sure we do, though, is that on the national level, is that we're incentivizing and paying in a way that rewards this sort of activity. And right now, during COVID, a lot of that has been incentivized, but as we think about moving forward, we don't want to lose that. We don't want to go back to really rewarding face-to-face or in-person, or not using this lower cost, much more highly dependable and reliable ways of providing care and keeping people connected. And not having to go back to more in-person activities. And I think that that's a really big opportunity for us as a country.
Yeah, and that is, and Kelly and Robert can jump in as well. We have a number of questions around that, the expansion of telehealth or other home and community-based services and the ability for them for incentives for them to be paid through insurance plans and through Medicare and Medicaid, and the ability to expand that. Because it is, as Abby, as you're talking, you're reminding us that we've been in this inflection point and it's really tipped. And many of these innovations need to be scaled even further. So I don't know, Kelly, if you want to jump in. You definitely have experience in this space.
Yeah, I completely agree with everything Abby was saying. just add that I think we probably need a more organized effort to train people on these modalities, and at home too. It's definitely needed within the long-term care facilities, and they have been underfunded for many years. They never benefited from the high-tech dollars, and have been advocating that for many years, but we were never able to reach them. But at the home level, at the patient or person level, the family members aren't always there to help. I mean, I know I was there to help my parents in recent months, and it was sometimes just a browser issue, right? It's an easy fix, practical things that they need help with.
Yes.
But getting a more organized volunteer corps, whether it's senior corps or multi-generational training, college students being deployed, there could be more organized volunteer opportunities to help people. And that could be coordinated with our social isolation campaign as well. And the Meals on Wheels and others are already starting to do these things, so we can build from it. So I'm encouraged, and I think we really need to double down on how do we make this easier for people at home. But also as it pertains to, how do we start to expand doing virtual home and community services, building from our experience in recent months. I think, there is several opportunities both within Medicare and Medicaid. I think, we're collaborating with CMS partners on. Some of you might be aware that CMCS just released an HCBS toolkit that has a lot of really good, valuable information on how states can start to think about rebalancing and shifting away from institutional care and more definitively trying to promote home and community-based services. I think a lot of people are excited about the concept of having HCBS as a default, and what would that take? What are the set of policies at a state and federal level to support that? That's probably going to be an ongoing conversation for quite some time, because it's a very exciting opportunity. And even in recent years, I think ACOs have tried to switch to that, whether it's, short stays, for knee replacements, hip replacements, and avoiding a post-acute stay as clinically appropriate. There's lots of examples, I think, to build from of how we could be moving away from post-acute long-term care stays and really supporting people at home. That's really exciting. But there's an awful lot that needs to happen for workforce development, for how state leaders could be supported in that policy shift in a time when they're very taxed and they're pretty overwhelmed. And there's a lot of transition and layoffs and financial constraints. There's a whole set of things they need to overcome. But fundamentally, I think expansion on Medicaid is really there's a lot that could be done in the next 1 to 2 years. Medicare, I think our main opportunities through Medicare Advantage and supplemental benefits, or potentially through value-based insurance design, because people can be proposing through the CMMI authorities to be expanding on Medicare Advantage that have services that could be home and community services that address social determinants, keep people supported at home, and end up being cost effective. So we're even self-direction models could be more explicitly tested in Medicare Advantage. So we're very excited about that opportunity, but that's under existing authorities, in terms of what we have to work with today.
That's right. Well, you've all hit on many of the questions that were coming in regarding also, the ability across the life course to have a range of choices about where you live, with whom, in which communities, and to be able to make those choices for what level of independence, works best for you. Other issues that are coming in are around volunteerism. So I'm glad that Kelly touched on it, and maybe Robert and Abby want to jump in here as well. So a couple of individuals have asked questions about your thoughts on university students working with older adults. So Kelly touched on that. I know at AARP Foundation, we've invested in some of that work. We're a big believer in generations coming together. Volunteerism itself is preventive for isolation. At AARP Foundation, we have AARP Foundation Experience Corps, where we're working in underserved school communities with older adults of the communities are literacy tutors. So we're addressing poverty across generations, but we're also addressing the power of connection and health across generations. And right now, as you can imagine, our students in many cases are not in school, and they're doing remote learning, which can be challenged in underserved communities for all of the issues that we've brought forward about digital access. And our tutors didn't want to leave their students. So now we're getting Chromebooks in the hands of our literacy tutors and training them on the technology tools, and they're highly motivated because they want to be with their students. And I think this will really prevent isolation for the volunteers and cross-generation connections. But Robert or Abby or Kelly, do you want to speak more about what you're seeing in terms of volunteerism across generations and its relation to addressing social isolation? Robert, I saw you were going to jump in.
Thanks, Lisa. Yeah, it's a great question and a real promise, a real need. A few years ago, I worked in the LGBT aging field, and I worked for a senior center in New York City. And we ran a friendly visitor program where volunteers would be paired with LGBT older adults, ideally those who were more isolated. And they would form these relationships where the visitors visited, a set number of times a week, and offer that kind of interaction and support that can be life-saving for many people. And in the context of LGBT aging, it also allowed for intergenerational dialogue and intergenerational transfer and preserving history, right? There's so much history, I think,
Yes.
and among younger people as well. And so I think there's a lot of promise for that. And of course, it was underfunded. And so from a policy angle, from a private angle, the more we can invest in volunteer now programs, especially in that's a big need. In the direct care sector, I think it's an emerging practice. We are
Yes.
seeing, should we be thinking about developing volunteer caregivers who can provide maybe kind of less level support for older adults that rise to the level of direct care? I think that it's an intriguing idea. One question that we pose, that I would pose to the full group, is to think about the level of training that would be needed for volunteers if what they're offering support might veer into something that needs more skill. And so just and what are the kinds of liability questions? Like just how is it properly structured so that no one can in either direction? But certainly it's a question.
Yes. Well, I'm going to ask a lightning round question. And before I do, Robert, I'm happy to share with you that AARP Foundation is continuing to work with SAGE on some intergenerational work and issues around isolation in some of their new housing centers that they've opened in New York City as well, which is great. So we have a ton of questions in the chat. I cannot believe our hour has moved so fast. I want to say before we wrap up, Robert, Abby, and Kelly, how thrilled we are at AARP Foundation to know you, and we're privileged to work with you as leaders in this space. And we're all in to solve for isolation across the life course with all of you. But I would like each of you to quickly share in the near term, the pandemics are continuing, and there is much to work on. But what would you want leaders or practitioners in the field of social isolation to be focused on in the near term? Kelly, I'll start with you.
So I think having a really organized effort to screen and assess more and to be able to refer people to resources will be a really practical step that a lot of different people can take, whether you're a caregiver, whether you're a clinician, whether you're a family member or an individual in need. I think everybody can play a role in that process. And just a very brief mention that we do have a challenge competition going on right now to create a clearinghouse of all social isolation programs and technology solutions and an upfront interface where people can be screened in an efficient, user-friendly way and taking into account preferences, values, capabilities, and then matching the results of that screening to a set of solutions or a solution for an individual. So that's something that clinicians can use, or that any of the people I mentioned could use. And so having like a practical tool like that to try to get a lot of uptake on will help us reach our goal of meeting 10 million people who are socially isolated in the next year or two.
Great. It will help CBOs as well across communities. Abby.
Well, first, I just want to again thank AARP Foundation for the projects that we're working on together and the impact we're potentially going to be making as we continue to move forward, connecting CBOs with the larger delivery system. So I'm going to expand on that. I think that if we could find a way to pay for, reward, incentivize more home monitoring, we can keep and help people age in place in their homes. So I think it would be really exciting to really expand on a national approach to really providing care in the home and finding ways for multi-generational families to help support each other, because especially in our populations, that would really fit with how they live. So
Great.
I think I'd really like to.
Thanks. Robert.
Sure, I'll keep mine short and sweet. I think we need a national strategy on social isolation and loneliness, and with an emphasis, of course, on older adults, but recognizing broader than the population, and that would connect all of them today.
Great. Well, thank you to Kelly and to Robert and Abby and all of your near-term priorities are priorities of AARP Foundation. So again, know that we are with you in developing a national strategy and working on solutions for technology-based ability for individuals to remain at home and remain connected to services as well. And as Kelly said, evidence matters. Creating a robust collection of evidence, not just on diagnosis, but on solutions that are designed thinking about the interrelation of social determinants of health and are evidence-based and can be deployed and shared and scaled broadly. Thank you to all, and the work continues, and I'm happy to be in the work with the three of you. Thank you all.